while I was in school, undergrad, my granddad had a stroke. And so I did get to live through it as a family member. And I was like, oh yeah, this is what I want to do. Yeah, I think what's neat about OT is that you never know where it's going to go and what opportunities you might find from it. And again, my passions change often. And so I think that's what's really, really cool about what we do.
Hello, and welcome back to UNA Talks. My name is Lee Taylor. I'm your host, and today I'm joined by Dr. Laura Smith. Thank you for being here, Laura.
Thank you for having me.
Laura is an assistant professor in the Anderson College of Nursing and Health Professions, and you are the program director for our new occupational therapy program at UNA.
Yes, I am.
And you are also, that program is now officially housed under the Department of Health Professions within the college. Is that correct?
Yes.
Very cool. So before we just had the College of Nursing, undergrad and graduate, and occupational therapy, respiratory, all of these kind of new and emerging programs that are adjacent to nursing but not directly related have sprung up over the last few years. So now the Department of Health Professions is going to house sort of these really cool, innovative programs that we have coming up that you're a part of. So that's really cool. Tell us a little bit about yourself and your background and sort of how you got here.
Yeah, so I've been an occupational therapist. This is my 20th year, actually. Graduated from UAB in 2005, and my undergraduate degree is in psychology. And so I have worked in a lot of different areas in OT, which I think makes me pretty well prepared to be an instructor because I can teach a lot of different things. But I have worked in inpatient acute mental health. I've worked in hospital, acute care hospital. I've worked in an outpatient clinic. I've worked in home health. And that kind of goes to show where all OT can be.
Right.
And then I started in academia, taught for 5 years at a community college, and then was the program director there. And then when this opportunity came up to come here, I started here last January. So I've been here like a little over a year, and I'm really excited to actually start teaching again here.
Right.
And I also work part-time at a inpatient acute mental health facility. So I've kind of gone full circle back to where I worked before.
Whenever you say acute health, what does that mean for the uninitiated?
That is usually when someone is in mental health. They're in a crisis state. So it's typically with kids, they've made some kind of statement that they want to hurt themselves or hurt someone else. A lot of times that happens just because of anger, but they've made some kind of comment that they need to be stabilized and have their medications looked at. So we work in conjunction in that setting with the doctors, the nurse practitioners, and the counselors. But then in the hospital, that could be someone who has had, like a traditional hospital, someone who is needing to be hospitalized for something like a heart attack, dehydration, something respiratory, pneumonia, something where they can't be managed at home.
Right. Thanks for sharing that. And so that's kind of where you got your start, and that's where you found yourself back as far as, your day to day. What are our programs looking like for this, for this new, or I should say our coursework and things like that looking like for this new occupational therapy program that's coming up?
So we're actually going to have two programs. We're going to have a bachelor's level occupational therapy assistant, which that's kind of a new and innovative program. There's only about maybe less than 20 in the whole country that have a bachelor's level OTA. We just feel that it's such a unique opportunity to have both programs here, and to offer that as a bachelor's program. Then our students would be able to turn around and have the degree required to do the master's if they want to. And so we will have that, and that starts in January of 2026, pending accreditation approval. We've submitted all of the information for that. And then we will have a master's level occupational therapy program that will start in August of 2026, again, pending accreditation. But we've been approved at the school level, the state level, the regional accreditor. So now we're just waiting on the national. So we're excited.
Yeah, so I've gotten to be a little bit of a part of that journey with you guys. And I think it was right after I started working here that we got to talk, not long after I started. about all the needs were going to be there, and I quickly realized, this happens a lot, that I really just didn't have a lot of literacy around what occupational therapy really is. And like we talked before, and you mentioned, this field of study and this practice has been around 100 years. But I think there's more and more people like me who have maybe heard of it, but don't really have a lot of literacy around what it really is or what its distinctives are. So if, again, for the uninitiated, what is occupational therapy sort of in a nutshell? What all does it cover? Because there's, you have a degree in psychology, and you're also working with people with physical needs and all of the things in between. So what does occupational therapy cover? And then what are the differences or maybe some of the confusion that people have with it compared to like physical therapy or other forms of therapy?
So I think the key term is occupation, which a lot of people, I've had a lot of elderly people say to me, occupational therapy, but I'm retired, because you tie that word with job, right? Yeah. But the way we describe occupation is just things you do that occupy your time. So that's so variable with each person, right? And so I think that's why people have a hard time kind of understanding what we do, because it is very client-centered as to what are the things that are purposeful and meaningful to them, what do they want to participate in, what has been impaired based on whether it's they were born with something that keeps them from being able to develop appropriately or on the timeline that other kids do, versus an adult who maybe had skills and then had some kind of injury or illness that keeps them from getting back to doing the things that they want to do. So I think that's why people have a hard time knowing what OT is, because it's very specific. OTs that work in, like an acute hospital, we work very closely with physical therapy. I always say physical therapy and OT are kind of like peanut butter and jelly. We go really well together. Right. But we're looking at, PT is going to get someone up and look at their gait and their balance and their ability to, maybe their strength. OT is looking at what are the occupations that have been impacted by this. Can they get to the toilet? Can they put their clothes on? Can they brush their teeth? Can they comb their hair? Can they fix themselves a snack when they get back home? Mm-hmm. Are they able to return to their job, right? Like, it kind of depends on what all has been impacted. A spinal cord injury, if someone's now in a wheelchair, what does their job site look like? Are there accommodations to help them be able to return to do their job successfully? So we really, can veer into so many different places based on what the person wants to do, needs to do, has to return to doing, or what skills they're trying to gain as they grow. The primary occupation for kids is play. Mm-hmm. And so it looks like a lot of fun when you see a pediatric occupational therapist. Like a lot of the pediatric clinics right now are doing water week. And so kids are getting to participate in swimming and outdoor play, water balloons and fun stuff like that, because those are developmentally appropriate and things you want to be able to do with your peers. And so, again, it just kind of looks with whatever they want to do. But that does make it hard to kind of put in a nutshell what we do.
Well, it's and from what you've described in the past too, it's sort of the missing link between, or it serves as the missing link, I should say, a lot of the time between what somebody's individual goals are and what their whatever's obstacles are sort of in their way, either with their behavior, their speech, their body. Mm-hmm. Occupational therapy is a great way to sort of blend the gap that they have between where they are and where they want to be. A lot of the times it's the what their goals are in their field. If they want to get back to gardening, if they want to whatever. And so what about occupational therapy sort of tends to get it earn the label of like holistic care? Because that's a term that gets used a lot, and I don't know if that's accurate or not. So I'm genuinely asking, what about it earns that label, so to speak?
I think it's really holistic because we look at the entire person. I mentioned I work in acute mental health, and so people a lot of times who know me from a different space, because I worked for 8 years seeing people in home health, which was more of people who had just discharged from the hospital and then were kind of getting back to doing their life. And a lot of times those were more physical impairments. And I say I work at this acute care psychiatric hospital, and they're like, well, what do you do there? And I'm like, well, I do OT. And they say, well, why? What's that look like? So these are kids who, if you think about their occupation of education, so they're trying to sit through school. And we see a lot of kids who have ADHD, autism, trauma, complex trauma. And if you think about like the ability to sit through school, a lot of times is impacted by a lot of those situations.
Right.
And so just being able to respond to their environment, to interact with their peers appropriately. One of the big areas I think that OT has a specialty in is sensory processing, sensory integration. So that could be, your five senses. So sometimes kids are really overwhelmed by sounds. Well, if you think about school, there's bells, there's teachers that sometimes yell to get their attention, right? Their peer might be erasing something on their, on their work, right? It could be that there's weird smells coming from the cafeteria, or their neighbor didn't put on deodorant right after they got out of gym, right?
Yeah.
Or maybe mom got them a new shirt and it's got a really itchy tag in the back, or they've been sitting in this chair. Kids, as punishment, a lot of times now, teachers take away like PE, which we all need to move our bodies.
Yeah.
And so having to sit still, and then a kid that needs to move and then is being forced to sit still, it just creates more issues, really.
Right,
But all of those senses a lot of times can be something that does not allow that student to appropriately participate in school. And so when I get them, a lot of times I'm looking at, well, what accommodations can we make for that kid when they get back to school? Because something has happened to the point where they've been removed from school and have to come to the hospital. And so I look at, do they maybe need to wear noise canceling headphones when they go back to school? Should we build into their individualized education plan, their IEP, that they get a movement break, that they're allowed to go to the calm down corner at school, which a lot of teachers are getting really great about adding those things. Maybe they need to have, when they recognize that their body is getting overwhelmed, that they have that ability to go to that space. So that's a lot of what I'm doing, is identifying that and helping them learn about their body and learn kind of how they, how they might need to adjust and things like that, and make recommendations for when they leave.
Right. So that's the follow-up to that, what you just mentioned, is making those recommendations. So a lot of the times it seems like occupational therapists are not only bridging the gap between a patient and their goals, but you're bridging the gap between the patient and their environment and the people. So I would imagine you're making recommendations maybe even to their physician at times, and helping them sort of come to some different conclusions, or bringing another perspective to their teacher, to their therapist, to their
parents.
To their parents. What are these overlaps that you've experienced in the past, like where you're the sort of the authority that's helping them communicate what their needs are to other people?
I wanted to touch on what you just said about that adaptation piece. I think that is kind of our secret sauce in OT, is that we can take an activity or an occupation and break it down into its like smallest components and see what needs to be adjusted. So sometimes we actually do work on the person and help them regain skills. So we may look like another discipline in that we might have, work on some strengthening or fine motor coordination or something, particularly like a kid that maybe is struggling with cutting in school, or struggling like cutting straight lines, or an adult who's had visual impairment. We work on strengthening their eyes, or but sometimes they can't. We have to adapt it. So we can adapt the environment, we can adapt the activity itself. And I think that's kind of what's cool about what I do, is I'm kind of like a detective who goes in and figures out it's neat. I've been doing it for 20 years, and I get excited about it still, because it is so different. I think I would struggle if I had to do the same thing over and over and over. But I do think we are a great liaison between the patient and whoever it is that needs to kind of know more about them, because we are good at identifying what's missing, what's keeping this person from participating in this occupation. And so sometimes it is just the environment needs to be changed a little bit. They need a seat that allows them to wiggle a little bit, because they're someone who seeks input from their environment, movement based. Or maybe they're an adult who is having some decline in their vision, and but they need to work, and so maybe they need some kind of adaptation on their phone that makes their print bigger, or has more of a contrast to it. Or maybe they are someone who has to get dressed in a different way. They do it seated now rather than standing. I think that's kind of and then we make those recommendations to the family, like, hey, when they come home, maybe we work on, this is a different way that you could set up your bathroom, or this is a way that you could, advocate for your child when they go back to school. These are some things that you specifically can ask for when you have this meeting with the teachers.
Right.
Definitely calling physicians' offices and saying, hey, could you make this recommendation for this piece of adaptive equipment so their insurance will cover it? Right. Sometimes we call insurance companies and we say, this is why they need more visits, because we've achieved this skill, but we still have these deficits.
Yeah.
So I definitely think we become a great patient advocate because we have a way of kind of seeing the whole picture.
Right.
And that goes back to that holistic piece. Also, just like being able to recognize that you may have a physical injury that happens, but how does that affect you mentally when you can't participate in those things? We look at the whole piece.
Yeah, and it's such a necessary component, but one that, because of its maybe lack of specificity, it's not as prescriptive. It's a lot more diagnostic, right? Mm-hmm. You're not necessarily like getting a note. In my mind, because I don't really know how all of these systems really work anyway, because it's not my area of expertise. But in my mind, it's almost like you get a note from their doctor that says, "Hey, you need to help them do this." And it's a lot more of the reverse, where you're saying, well, here's the piece that's being affected that I'm noticing, mm-hmm. that is not maybe as obvious to somebody whose job isn't to look at the whole picture.
Right.
A cardiologist's job is not to necessarily look at what their environment is like. It's just to help them, lower mm-hmm. their blood pressure or whatever that is, right? So you're looking at all of the potential things so that's really fascinating to hear, and I think that helps paint a picture in my mind for somebody who's just new to this, to understanding really what this looks like. How do you talk about this too? And maybe it's the same what we've been talking to. How do you talk about this to, students who are wanting to, pursue a degree in health professions, but, maybe they're a good fit for OT and they don't know it? Who is that student? What are they maybe looking at? What are the things that they're passionate about? And where does occupational therapy sort of help them find their niche?
I think the way I've been pitching it is through some fun. We just did a relay race at the host today, and so I was showing them different areas of occupation that they could work on. We did the health professions camp recently, and we did a whole Harry Potter themed traveling through we have 9 areas of occupation that we talk about, and that just includes basic care things all the way up to work, education, social participation, sleep, and like kind of how all that fits in. But I think your OT or OTA student is going to be someone who enjoys problem solving, who enjoys being creative, who maybe knows they want to help people, but they don't want to be pigeonholed and stuck with a patient the whole time. I always make that joke around nurses because, I'm outnumbered by nurses a lot in our department. But, nurses, if they have a troublesome patient, they're stuck with them for that 12-hour shift, whereas I go see them for therapy and then I give them back. Kind of like the same with a teacher. They have that patient all day or that kid all day, and then I'll have them for a part-time. But that is a joke. But we love our nurses. But I do think that OT is not something that is easily describable, and so a lot of times I just want to show them. So I'm really excited when we have our they're remodeling Stevens Hall for us, the first floor of that.
That's right.
And I'm super excited to have students come and just kind of go through. We're going to have this big pediatric lab that's going to have all of these we're going to have a climbing wall and swings and all these really fun games and toys, and we're hoping to bring kids, touring groups through there, as well as anyone on campus that wants to come. We'll have an open house hopefully once it gets done, but hopefully in the fall. But I want to show them, because I think that's the key to OT, is really being able to see, hey, I have an interest in art, but I don't think I want to just do art. I want to help people with art. Well, you can do a lot of art in OT. You can do a lot of music in OT. If you're interested, engineers make great OT practitioners, so do teachers, because you have a different way of problem solving. So when you bring that to the table, we don't want everybody to have the same undergraduate degree for our graduate program. We want to have different thinkers from different areas.
Right, like yourself with a psychology degree, and there's a lot of diversity that goes into that, I'm sure.
Yeah. I think people who enjoy, any type of leisure activity, gardening or reading or adaptive sports, they're all different people that have niche areas in OT because of an interest that they have. OT kind of gives the lens. You come out as an entry-level generalist, but then you can specialize and really, take what you love and make it, because OT is really everything, because everyone who has an interest, that OT can work on that if there's a need. So I think there's not one particular person who is better suited for OT, but I think there's people who don't want to do the same thing day in and day out, I think would make really great OT practitioners.
Hey, I hope you're enjoying our conversation with Dr. Smith. I certainly know I am. I just wanted to take a quick break to thank UNA, who's our sponsor for this episode and every episode of the podcast. No surprise there, but if you wanted to go to una.edu/online, I would encourage you to do so, to look at all of our online programs. We have a vast array of disciplines that we teach online. And we have excellent program coordinators like Dr. Smith and others across the university who are happy to talk with you, answer questions, and talk to you about our programs. So you can look those up right there. You can also see our scholarship opportunities, partnership opportunities. All of those great things are right there for you. And also, if you're not following us on social media, we're on Instagram, we're on Facebook, LinkedIn, X, formerly known as Twitter, and of course now YouTube with this cool stuff that we're doing here. So thank you so much for tuning in, and now we will get back to talking with Dr. Smith. So occupational therapy has been around 100 years. But there's a lot of recent evolution in this field of study and in this practice, and it's so multifaceted, it's so complex, but very singular in its mission, it seems like. So what are some of the latest innovations that are really exciting that you've seen and that you're developing these programs around to help students be prepared for?
I think it's really interesting to think about even just where OT came from. The original OT practitioners were a nurse, a doctor, a social worker, a teacher, and an architect. Those were the people who in 1917 created occupational therapy. And what I think is neat about my profession is that it is ever evolving. I think about when we were in World War I and World War II, we had people who were going out into war and coming back and being, having injuries that needed rehabilitation. And so OT was in the forefront there of helping, helping people get back to doing activities. But the original idea of OT was that invalids who were in the bed benefited from participating in something that kept their mind going, occupation. Yeah. And so as OT has traveled through the years, we kind of adapt to whatever need exists. I think about in the 70s, deinstitutionalization, all of these people who were living in mental hospitals were kicked out on the street, basically. Wow. And so now those people, they needed community-based resources, and so OT kind of adjusted to that. I think about there's a lot of really amazing researchers who are doing work with the unhoused population and how life skills and medication management and even things like that. I think that's a growing area. There's OT that are working in the prison systems. If you think about someone who has been in prison for 20 years, think about all of the adaptations in technology, how we even access our data at a doctor's office, even just technology use is an area. Maternal health is a really big area in OT. Just recognizing that women's bodies are changing and there's so many things that are happening. The pelvic floor has kind of become a big area of interest for physical and occupational therapy. And again, that can be anything from incontinence to sexual health. But there's so many different things that people who just specialize in that, that can be a whole practice there. Yeah, sure. And there's a mental health component to that too. And I think what I've done my research on in the past year is on trauma-informed care. So kids who have lived through trauma, and that we all lived through COVID, which was very traumatic. Kids who were, getting their socialization at school, whose parents were trying to work and keep them at home. I mean, the expansiveness into pediatric care, we're seeing practices grow at huge volumes because these are kids that are really struggling developmentally after living through that. So I think there's I think what we're really good at in OT is kind of identifying what needs come about. I also think legislatively, those are some things that I've kind of had an eye on. I didn't realize how much bills would impact our practice, but in 2019 and 2020, there were these two really big bills that were passed to cap abuse of Medicare dollars. Right. And so when that happened, it changed how payment happened in skilled nursing facilities and in home health. And both of those models were driven by therapy reimbursement before that. Right, and then those cuts happened. There's also been big cuts to hospital reimbursement too. Hospitals lost money when people were readmitted to the hospital within 30 days. And so with all of that happening, we've had to adjust how we respond and how we may not get as many visits with patients that we used to. And so I think we have to really look at how OT can adapt and evolve to that as well. But I think we look at, what's happening in the country, what's happening, what are big idea areas that OT can fit into. And I think that's what's cool about what I do is that it's always changing. And so my interest areas have changed throughout my career, as I hope that students will have, ever evolving ideas as well.
How is, online how does, I guess, occupational therapy translate online? How does the online space, or I'm sure during COVID, there was a lot of innovation that sprang up, just like instruction and everywhere else. Yeah. But conducting occupational therapy, whether it's speech therapy or whatever you can do, not in person. What does that look like? Or I guess from in the work that you do a lot with, it seems like a lot of young people and helping them sort of overcome those situations and those obstacles. What does that look like necessarily? Have you seen that grow a lot in the last few years?
Yeah, so telehealth is a really big area, especially in like rural and underserved areas. Yeah. Telehealth is really big.
People who can't get to a doctor as easily as other folks. Yep.
Or a therapist as well. So there's been legislative, there was a telehealth bill that was passed, an emergency telehealth bill. Yes. And so our lobbyists at the national level have actually been lobbying for that to be extended, because we saw the value of reaching those areas where there maybe aren't as many OT practitioners to serve that population in person could be met with a telehealth need. But also that nursing has what's called a compact license, where they can work in many states that have that passed, and we went to do that as well in OT, is have a compact license. It has passed in many states, but we were still waiting federally to have that kind of enacted. But that will be really cool once that does finally get in place, because then you can do telehealth across state lines. You can do it. You can practice in different states, like especially here at UNA, we'll probably have students who come from neighboring states, and then they could have a license to work across the line in a way that could be kind of cost prohibitive to have a license in each individual state. You could have a compact license and work in different areas. So we're hoping that I think they're planning to roll that out this year, or maybe the first of next year.
And remind me, is the OTA program, it's going to be pretty rare for our region, right? There's not going to be another one with a pretty decent radius.
There's only one other OTA program in the state, and it's an associate's OTA program. Right. Yeah. Okay. And so yes, we will.
The first bachelor's of OT in the state of Alabama. I knew there was like some exclusivity to that. I just couldn't remember exactly. So yeah, for sure, we're going to have people coming from all around to be a part of that, which is super exciting. We always love bringing in our friends from neighboring states and nearby to be a part of this.
And there's not an OT program
Right.
in the north as well. The closest one is in Birmingham. So we're still going to be drawing, I think, a great number of local students across the North Alabama area. But I definitely think we're going to see kids from other areas too.
Right. And so what is because it's so diverse, right? Always going back to sort of the challenges of a specific practice that has that's so multidisciplined just by nature. What are some of the more common undergrads that you do see? I know you said yours was in psychology. For this master's level program, what are some of the undergrads? Is it just all over the spectrum, or is there some pretty consistent ones?
I think UNA has a great exercise science program, and they have been kind of prepping people for OT school for a while.
Well, that's been a pretty common. I talked with a student recently who was getting their exercise science degree so that she could go to OT school.
Great.
Or she was doing physical therapy and occupational therapy at the same time, which was
wild
intense
to me.
Yeah.
I do think psychology is a great fit, but I really like when you get somebody from somewhere random. In our program, we had someone whose background was in engineering. We had someone whose background was in culinary, which is really interesting. I think architecture, the problem-solving piece, that engineer brain, that STEM brain, all of those things can be really cool. But again, knowing about people and what makes them tick, I think psychology, sociology, also like dance, movement-based degrees would be really cool. Art, music. I don't think that there's a bad, especially if you have a cool interest that you can then turn into using that to help people. I don't think there's really a bad degree.
I just went to my high school reunion, 20th high school reunion, and a girl I graduated with has been a music therapist now for like 15 years, and that's what she got her degree in specifically. And it wasn't until I talked with her at this reunion that I realized, she's like, well, now that program is lumped in with occupational therapy and not in the School of Music, where she went to school. And so that really opened my eyes to understanding just how comprehensive this practice really is. But there's a lot of clinical knowledge that she has to have. She spends most of her time in nursing homes, so she's playing a lot of the folks who are later in their life want to hear like older music and stuff, and that's like what she does for a lot of people. And a lot of them are in a hospice or in the last years of their life, in the last seasons of their life. And just an incredible sort of perspective that she has on, what she's able to do just by, bringing her gifts into this field, but understanding how that connects to their well-being, and not just something nice to do as a volunteer, but like really understanding how this connects to their well-being and their health is it unleashes sort of this entire, almost, not almost, but entirely clinical application. And so that was an eye-opening conversation for me, because that's something I haven't even considered as somebody who has a musical background myself, that it was really that capable of a program that she was a part of. What do you think is kind of the future? I mean, we'll talk about some of the programs, specifics, how we're addressing some of these things, with these programs that are upcoming. But what do you think the future of occupational therapy is? Is there sort of emerging needs that it's able to meet better than other practices? And what does that look like in this time that we're in 2025, 2026?
Well, I think when we think about the baby boomers, they're aging. And I think that where people used to end up in skilled nursing facilities, nursing homes, people want to live at home. And so there are specialties, people who do certified aging in place specialists called a CAPS certification. I think there's a lot of OT practitioners that are going into that world, because we know how important it is to have our space and to have our all of our things around us. And as long as someone can stay at their home, they can. I think about my parents. They want to live in their home as long as they can, but they have lots of stairs to get into their home. And so they're looking at doing a remodel in their garage to be able to have like a lift so they could get in from the garage into the main level. And so I, have consulted for my parents on helping them, be able to do that successfully, making a recommendation to vendors and things like that too. But I also think emotion regulation, trauma-informed care, I think is a really, really big area where OT can look at all of the components of what's going on with a kid. And I think that's an area where we are really easily stepping in and partnering with the special ed teachers. I just did my doctoral research and I did these workshops with teachers in particular who are saying, I don't know how to work with these kids, or we know how to work with these kids, but it's really hard because all these kids have different needs. And so kind of some recommendations of specific things to do to help manage a classroom, because we know schools are overcrowded. I mean, teachers are doing all they can do.
Yeah,
and they don't get paid enough.
Challenges with, the hot topic around that is the challenges of technology and being distracted by phones, and parents wanting them to have them, teachers not, and among a litany of other complications in the modern world for sure. So yeah, it sounds like OT is really needed to sort of help bridge that gap in that space.
Definitely.
And I want to rewind a little bit and just kind of get to something I meant to ask you earlier and I forgot, but why is it that you're passionate about this? Like, what about, not just what led you into this practically, but what is the personal connection for you? Because I feel like this takes a lot of focus and passion and discipline to really be committed to, as any healthcare profession does. It takes a great level of empathy to be passionate about it and to pursue it. Where does that start for you, you think?
It's interesting because a lot of people in my former program, they would say, well, my grandparent had a stroke, they lived through this. And I honestly was an athlete in high school, and I looked at what's something I can do where I don't sit behind a desk all day. And I took an aptitude test, and it said I should either be a physical therapist or an occupational therapist. And I had a really great psychology teacher in high school, and we had worked with the wing of kids at school that had developmental delay. They called it the developmental wing. And we did all these really great, cool projects with them in that class. And so I knew psychology was more my focus rather than organic chemistry, which you have to take a lot of in physical therapy. So, and I also knew I wanted to go to Alabama. That was kind of where all of my family had gone, and so they had a pre-OT track there, and so I looked into that, and then kind of realized psychology was what my major was going to be. And then while I was in school, undergrad, my granddad had a stroke, and so I did get to live through it as a family member. And I was like, oh yeah, this is what I want to do, because I got to watch his OTs help him do all kinds of things. His was a really significant stroke. He had paralysis on his dominant side, so his arm didn't work, his leg didn't work very well. He was the family storyteller, and he could not speak really well at all. And so just watching that as a family member, and then my grandmother had a condition called macular degeneration, which is a vision deficit that can't be corrected with lenses. It takes your central vision away. And she was actually really lucky to go to UAB Callahan Eye Center, and they actually worked with OTs who specialize in low vision, and they taught her to use her peripheral vision as her primary vision. So if you think about that, that's like, wow. I tell my students to do that, like put your hands in front of your eyes and then try to look out she could watch TV like that. She could know who was coming in the room just by using her peripheral vision. It took away the two main things she loved to do, which was read and drive, but she was still able to interact. She could read cards when people sent them to her, because these OT, and it's not like that all, like Birmingham has a really specific low vision training program that is, I was able to be a part of that because one of my instructors at UAB was like the pioneer of how OT could get into that low vision world. And so I got to work as her research assistant, got to see a lot of really cool things. And so I think that being able to be involved in all of that, even before I went into OT school, I kind of got connected even more with what I wanted to do. But I've worked in some really cool places. I've gotten to see some really interesting things. And then I think the big thing that got me super connected was getting involved with our state association. I've met so many passionate people who were really teaching about the cutting edge things. And I'm really big in that networking and connection piece that we have through our state association. And I've been to our national conference many times. And again, those are people who are presenting like not just basic OT stuff, but what's new, things I've never even thought about. One of my teachers is doing this really interesting work with Tourette's syndrome. And you think, well, what does Tourette's have anything to do with OT? But she is actually in charge of a clinic that is one of the only clinics in the country that uses a behavioral modification to help combat a tic that a kid has with Tourette's. So like a vocal sound or a movement of the face or hands. With a behavioral component. So like think about a kid who maybe pulls their mouth a certain way. That can be really distracting to them and to other kids as well. But she can teach them to like press their lips together. So a behavioral change when they sense that that's about to happen. Have them do that instead of medicating that child. And they might also have medication because Tourette's is an anxiety disorder, or it's in that anxiety category. But having that, helping them have more awareness of their body and being able to have control over it. Like I would have never put that all together for OT, but I think that's so interesting and unique. And now there's lots of people that have trained under her and are now doing that in our country, which is really cool. But I think what's neat about OT is that you never know where it's going to go and what opportunities you might find from it. And again, my passions change often. And so I think that's what's really, really cool about what we do.
Hey, I hope you're enjoying this conversation about occupational therapy with Dr. Smith. Wanted to take just a quick moment to remind you to visit una.edu/online to learn all about our online programs. We have so many cool things happening here on campus that we're able to do online with students every day. So whether you're local or you're watching this or listening to this from across the world, go to our website and you can interact with UNA. At any time, you can talk with our program coordinators, our recruiters, check out all the programs that we have, learn about our scholarship opportunities, whatever interests you there. And if you're not already, make sure and follow us on Instagram, Facebook, LinkedIn, X, and YouTube. And so we'll get back to our conversation now. Thanks for joining in. So we talked about, we just learned about sort of your connection and how you fell into this. And I love, hearing about how really, OT is just kind of an outlet for you as somebody who just loves to see, how things change and evolve. And it's never the same one year to the next. There's always new innovations coming up, and it's always seems to be at the cutting edge of things as a practice. What got you into teaching specifically? Why are you passionate not only about the field, but about working with students and teaching them?
I come from teachers. My mom was a teacher. My granddad was a football coach and teacher as well. And so I think it's always been in my nature. I don't know that I knew that always, but I also have had 3 back surgeries. And so I knew long term I might not be lifting patients forever. And so I started looking. I met some really cool people who kind of connected me to doing some educational things with our state association and kind of helped guide me towards teaching. And I realized once I got into it that I really love it. And I think I've had so many cool experiences in my former job with my students and just seeing how they've grown and what they've done in their practice. And we're super excited about the opportunity to have both programs here at UNA because we're going to have so many opportunities to have collaboration between occupational therapists and occupational therapy assistants, which is something that happens naturally in the field, but it doesn't happen very easily between schools.
Yeah.
And so we're really excited to create all of these collaborative opportunities here at UNA with both programs.
And what was your experience like, before, as far as you taught at a community college, and what have you sort of in the years that you've been teaching seen with students? What are some of the surprising things about the classroom and going from doing to teaching, right? Like that were maybe some surprising elements behind that of how do you communicate some of these things? Because it's a challenge to communicate the impact that it has and the multifaceted nature of it. How do you teach someone to do it really well? What's the secret to that?
Well, it's interesting because, I think students think that you have a teaching background and you really go from being a clinician to being an educator. And so you learn a lot on the job,
Yeah.
And so like for me, I had not been in the classroom for almost 17, 18 years at that point. And so how I learned was very different from how kids learned. And again, I say kids, but they're young adults. But, they had all experienced, most of them, COVID happened during my very first cohort of students.
Yeah.
And so beyond that, every class I had beyond that had experienced COVID as well. And so their learning had been interrupted. And so having to learn how to meet needs online, that was hard to do. We eventually bounced back to having in person. And I think OT is so hands-on that it has to be. There are programs that do hybrid, but for me, in person, I think is the easiest way to teach OT, just to see and trial things, which is how I learned as well. So that part has not changed. But I do think how we all access information. I mean, I am very guilty of learning things through TikTok. And I actually use TikTok as a teaching tool, because how better to show someone how to better to show a student how someone with a spinal cord injury gets in and out of their car than to show them how someone who's had a spinal cord injury gets in and out of their car on a short, less than 3-minute video. Versus YouTube has things that are great, but they're really long. And so if you're trying to teach several different diagnoses at once, TikTok is a great way. So I think being relevant is a really important part of educating, and not trying to stick to how I was taught back in the the dark ages. Like having the ability to adapt, I think, is really important. I think having hands-on, we get a lot of kinesthetic learners, and so having the ability to not lecture for an hour, to have punctuated lecture, like a short little lecture, and then having an application within the classroom time, I think is important, where I can go around and kind of give my knowledge. But having students really learn well from interactions with each other too. And had a really great friend, mentor at UAB that was doing this stuff with team-based learning, and I got involved actually in a research opportunity where we did an escape room. And so I think learning that happens through experience is really, really important. And when I say we, I'm talking about my coworkers. But here we've really planned on having as many experiential things as we can have. And what's really cool about UNA is we have the Kilby School right here on campus. We have
my daughter's a student there. Yeah.
I love it. And our deans. Husband is the dean, and so we got in there, and that's really cool. Also, the Learning in Retirement Academy here, they've all volunteered to be our adult participant patients in the future. We did a lecture for them, and so there's so many opportunities here, and we're going to have the time with this bachelor's program and master's program. They're both 2 years, so they'll align in that they can have these experiences together. We have time to teach the content and then teach it. We're calling it a spiral approach. We have time to teach the content and then have them practice it in the community and like kind of a simulated setup, and we'll do it in lab, and then we have what's called a fieldwork experience. So they'll go for like a week somewhere and kind of get a little experience, and then they come back and we'll teach some more, and they'll do some research, because we really want this to be evidence-based, what they're doing. And then they'll go on their final internships. We call it fieldwork, but their clinicals or their 8 weeks for the undergrad, the OTA, and then they do that twice, so 16 weeks total at 2 different sites. And then the OT students will do 2 12-week at different places. So they'll have, by the time they get to that, they should have so much graded experience with us kind of supervising and correcting in a nice way, and helping them kind of feel, because I think a lot of times there's so much imposter syndrome when someone goes like they've learned it and they just think when they get out in the field that they're supposed to know everything. And it's really, you're a lot of times 5 years into doing something before you really realize what you're supposed to be doing. And that's tough when you get a lot of high achievers who are wanting to help people, and they think they want to know. I mean, I remember being that student. You think you're supposed to know everything when you graduate, and you can't. There's no way. OT is so broad.
Yeah,
there's no way.
Kind of the beginning in some ways, right when you graduate.
Yeah. And so, but I do hope that our goal is to have them have so many times of touching or learning something in a way that that feels safe, that then they can feel more confident when they get out in the field.
Yeah, much like the nursing programs, right? I mean, there's a reason that our simulation lab is, I talked with Dr. Will Brewer, and there's a reason the simulation lab has been this, really sizable investment, because it's so important that preparation, that practice, so that by the time you get into the field, it's muscle memory.
Yes.
It's, or clinical hours and all the things and related to therapy. You want them to be able to, that needs to be the last thing on their mind is, well, how do I move into this next thing? It might be scary, but they know how to move into it. Do you think that that's the earmark of success for an OT graduate, that when they're going into the field, that it's to expect the unexpected and just be prepared for what happens, because it is always changing. It is multifaceted. They may kind of shift their specialists, or their specialty, I should say.
Yeah.
Is it really, is that sort of the earmark for what a successful OT career is going to look like?
Yeah. When you were talking about what would make a great student, I do think being flexible and being able to adapt on the fly, which we will teach them. They don't have to come in with that, but not having a rigid idea of what they're going to do. So many people come in and they're like,
keep an open mind with this field. It sounds like,
because you may be planning to do to work on tying shoes with somebody, and you walk in and they have had an accident. So then now you're going to work on toileting because that person needs to be cleaned up. So you've got to be flexible. You may go in with a kid who you think you're going to do a puzzle with them to work on their fine motor coordination, but they may be having an extreme meltdown because they've had such a sensory overload all day that they just cannot tolerate sitting still for one more minute. And if you are not flexible, it's not going to work, right? And so I think, yes, that will make a successful graduate, is if we teach them, hey, this you got to change, you got to flex, you got to be more adaptable, and giving them the tools to do that. And again, hopefully we are so excited about the sim lab, and they've been so open and welcome to us. They are building us these 2 amazing spaces that we're going to be able to bring people in. Like, we really are hoping to partner with Kilby and bring kids in the aftercare program at Kilby to our pediatric lab and do stuff there. The nursing program has this wonderful respite program. We're hoping to have some of that run through our space as well. And then we're going to have this whole apartment where we can simulate getting in and out of bed, doing a load of laundry, cooking something, putting something up in the closet, all of the inviting friends in for socialization. All of those things can happen in our space.
Yeah.
Simulated, and then it's not as scary when you're walking into someone's home in home health and you have no idea what to expect, right? So having those experiences, I think, are going to be really, really opportune here, and we have the ability and the time to do that.
My department develops a lot of the media to help promote all the programs that we have on campus, and whenever this one came up, we said, well, what's the depiction here? What are we going for? And you're like, well, we're going to go to a playground with all these kids, and our students are going to be working. And that was, easily one of the most fun shoot days we've ever had. Was, we really got to see hands-on, like, their job is to ensure that these kids know how to are able to play the way that they want to. Like, that's their goal, and that's their occupation, is play. And so arguably that was like my favorite shoot that we've gotten to do, because you're just literally like trying to make kids laugh and like have fun, and it was super easy. They were really into it because they're in a playground. That's what they're there to do. And occupational therapists have a real gift in their work, where they really are there to sort of invite people into something that brings them joy or brings them fulfillment. And so it was just really eye-opening to see that this is the work. This is the result of hard work on their end, and to see just how instrumental something like that can be so quickly has been really cool. So I've learned a lot just by kind of being around this program and learning about it along the way. So it's been really fun. Laura, thank you so much for your time today. I could ask you a bunch more questions. I do want to, one more time, just make sure that our listeners and viewers know about when we're launching our OTA and our Masters in OT programs.
So our OTA program will start in January of 2026.
Okay.
Pending accreditation. I have to keep saying that.
Yeah, of course.
But applications should open in the fall.
Of 25.
Of 25, yes. And then we're working on the candidacy application with our national accreditor for the master's program. So it should start in August of 2026, and that has a specialized application system that's done outside of the school. It's called the OTCAS system, but we will have links to all of that on our website when we're able to advertise. But there is already, my information is on the pre-OT health track on the UNA website. So if anyone has any further questions, they can just email me.
And we'll make sure and put all that in the footnotes of in the comments of this piece here, so people can get to you and find you and ask you all sorts of hard questions, if that's okay.
Yeah, of course.
Cool. All right. Thanks so much for stopping by and listening to this conversation. We hope to see you soon again on UNA Talks. Thanks.